Okay, good morning, everybody. My name is Professor Paul Tipton. I am a Professor of Restorative and Cosmetic Dentistry. I am the Director of Tipton Training Limited and the President of the British Academy of Restorative Dentistry. Today's topic we're going to talk about is the DAHL appliance. And welcome to all of our international as well as UK graduates who are listening to this. So with DAHL appliances, let's just initially start off with what a DAHL appliance is. So Bjorn Dahl first described his DAHL appliance in 1975, Journal of Oral Rehabilitation, and the title of his paper was An Alternative Treatment in Cases with Advanced Attrition. And a DAHL appliance is very much an orthodontic appliance. But it's an orthodontic appliance that is used by restorative dentists. And the idea of it is that we gain space. One of the most difficult aspects we have in all of restorative dentistry is gaining enough space. Ask most technicians, whether it's on the labial aspect or whether it's occlusally or palatally, most technicians will tell you one of the major problems they have always with dentists when it comes to restorative work is they don't have enough space. So DAHL appliances will give you that space. So how does it do that? The DAHL appliance selectively allows certain teeth to actually intrude and over eruption to occur on other teeth. So it's a bite raising appliance, okay, that is just on several teeth, and it's on the teeth where you need to gain space. Works better at the front of the mouth, not as well as at the back of the mouth, where the condyles can start to reposition. They work far better for younger patients than they do for older patients. For younger patients, you have increased cellular turnover, and therefore the osteoblastic activity and the osteoclastic activity are happening at a much more accelerated rate. So we get much more movement. So when we're talking about DAHL appliances, very much a DAHL appliance is for the younger age group. We'll talk about our alternatives in a few minutes' time, but alternatives are then mostly for our older age group, where the DAHL appliance principles either will not work because cellular turnover is not quick enough, or works but it takes too long. So it creates, the DAHL appliance creates a localized space by using an anterior bite plane. So this is the important part now. There's some very, very important aspects of DAHL appliances which get overlooked by many people who talk about them. Okay, and what we need to do is make sure that we understand fully how the DAHL appliance should work. So it's an anterior bite plane. Okay, now here is another anterior bite plane. This happens to be a Lucia jig or an anterior occlusal splint. Now let's just go and recap what an anterior occlusal splint would do for somebody, okay? We put an anterior occlusal splint like this, Lucia jig in place, number one, to relax muscles, to get rid of muscle pain, potentially, to be able to manipulate somebody so the muscles relax. And we know that muscles relax very well with anterior bite planes and more quickly than with full occlusal splints. As the muscles relax, it also takes posterior interferences out of the way so that when the patient closes together, they only close on the anterior bite plane, posterior teeth completely out of contact. So that allows the condyles then to move back in and towards RAP. So the anterior bite plane, when it's in place, the condyles move to RAP, muscles relax. Okay, now just bear that in mind as we go through this process. So let's look at the technique for the DAHL appliance. And the technique is usually there. Remember, we want to create space. When do we normally want to create space? Well, we want to create space usually when we have worn lower incisors. We want to create some space to build them up. Or we have worn palatal upper surfaces where the lower incisors are actually meeting them, and we need to create some space to be able to restore those palatal aspects. So when it comes to our diagnostics, first of all, we've got 4 stages of the diagnostics which you need to understand fully. First one, as I mentioned, is mount the models around RAP. Okay, it is no good mounting the models in ICP. The reason for that is that when you create the correct shape for the DAHL appliance, which I'm going to talk about, if you've mounted round in ICP, and then by the very fact that you're putting this anterior bite plane in place, the muscles relax, the condyles go back to RAP, then the relationship between the anterior teeth that you've created on the DAHL appliance will change. So we have to mount around RAP because that's where the condyles are going to end up once the DAHL appliance is in place. So mounting around RAP is the first part. Second part is then we open up the pin by the restorative space required. Now, if you've got somebody who's got an RCP ICP slide, and we know that 90% of our population have got an RCP ICP slide, that means that when you take them back to RAP, you manipulate them and you tap them up and down on their RCP position, then there is space between the anterior teeth in most people. That space can be 1/4 millimeter, it could be 5 or 6 millimeters. So even just by taking them back to RCP, sometimes you don't need then to increase the vertical dimension or open the pin up because you'll have enough space. So mount the models around RAP, number one. Take the jaw registration out, close the models down so the teeth hit in RCP, and then assess how much space you have on the anterior teeth. It's usually the anterior teeth that we're dealing with. And if you have enough space between them to put your restorative material in, then that's fine. We can then go and just mount those models at that height and do our waxing at that height. So really, really important part, again, mount around RAP and then get the correct amount of space. Now, what happens if you've got too much space? Okay, if you've got too much space, then by all means do an occlusal adjustment so that that RCP ICP slide is reduced. You don't want to have too much space because remember the condyles are going to go back there. If you have too much space, then it means that the restorations palatally or incisally are going to be too much. So we have to work with our models so we get exactly the correct amount of space. Very important. And here we are, we've mounted around RAP, difference between mounting an ICP, mounting on RAP, and now we have space between the rest of the teeth, enough space. And in the case I'm going to show you, I'm going to have 2 to 3 millimeters of space. Next part is, again, very important that we create a horizontal ramp for the lower incisors. Now, if you can imagine, we're selectively going to have intrusion of certain teeth. So where we put the ramp in place, the teeth opposing the ramp will intrude. And the teeth that are not contacting the ramp will over-erupt. Okay, so we can selectively, wherever we want to, create that intrusion on some teeth and the over-eruption of others. And we do that by creating the correct size and shape of the ramp. Now, in order to get intrusion, what shape does that ramp need to be? Okay, intrusion. Let's have a look again at the lower incisor teeth. Let's just say I want to build up the lower 2112. Okay, what angle do the lower incisors need to hit the upper DAHL appliance in order to intrude them? Now, if we have them hitting on an inclined plane like this, so let's just say that is the normal palatal shape, incisor shape, okay, and that's the way that they hit each other. If we now just make the DAHL appliance so it opens up space at the back by making it 2 millimeters thicker, okay, and have the same inclined plane, what is that going to do to the lower incisors? It will move them down their long axis to a certain degree, but it will also move them lingually. Now, this is a very important part. If they move lingually, what's my problem? Okay, so if my teeth now move lingually and I then have space to put my restorations on the upper, if they move lingually, what's going to happen with the tongue? Once the DAHL appliance is off, you know yourself from an orthodontic point of view, muscles always win over tooth position. That's why we have to, at the end of orthodontics, put splints in place, permanent splinting, so that the muscles do not win. But if we don't do that, what will happen long term is the tongue will push those lower incisors forwards again. As the tongue pushes the lower incisors forwards, the lower incisors will meet the palatal aspects of the uppers, and something then will happen. We have lost predictability. It may be that the uppers start to drift forwards. It may be that we get pain in the lower incisors, that we get some mobility. So we have to, whenever we're doing a DAHL appliance, try to ensure, wherever possible, that the lower incisors hit a ramp at 90 degrees. Okay, so the lower incisors are now hit down their long axis. So this is what we're talking about. We're mounting our models and then we're producing this horizontal ramp. Okay, when I say horizontal, it won't be totally horizontal. What we're looking to do is to get the shape of it so it hits those lower incisors and the lower incisors now move down the long axis. That is our best chance of getting a predictable end result. Now, once we've done that, the other point that we need to make sure with the DAHL appliance is you understand that the DAHL appliance needs to have those retainers splinted together. Now, some people will do lectures, I've seen them, whereby they say, okay, just go and restore the upper anterior teeth first of all. Okay, let's again say that it's a case of palatal wear. Just go and put some palatal composites in place and everything will bed in, over-erupt, etc. Problems with that is in some cases it will happen, okay? But in other cases, what's going to happen is because those teeth aren't splinted together, because nobody's told the dentist to splint the composites, then one of the anterior teeth may start to drift forwards. Okay, because of the increased loading of the lowers on the upper anteriors. Remember, only maybe 4 teeth are touching. One of them may start to move forwards. And then you'll get some spacing in between the teeth, and maybe you have to go back and retract them and do some further orthodontics. So it's important that you splint them together. So I have no problem if you want to go to the final definitive restoration. But number one, make sure you've got that ramp in place at 90 degrees. So you've contoured the composites so they're at 90 degrees to the long axis of the lower teeth that you're going to push them down. Number two, you splinted the composites together. And you have to then go back at a later stage, once the DAHL appliance has done its job, and then unsplint the composites. So those are our 4 defining principles or techniques to get the DAHL appliance to work predictably. And this is what we're out. This is what we talk about throughout all our courses with Tipton Training and the British Academy of Restorative Dentistry, is predictable techniques, not techniques which will work now and again, or will work 5 or 6 times out of 10, techniques that will work 99 times out of 100. Yes, there's always going to be a time when something doesn't work. Our patient does not do the right things or is not predictable. But most of the time, that's what we want. 99 times out of 100, it works predictably. And here is now our splinted retainers. So that's the same case you've just seen, waxed up and then again splinted together. So we're now going to go through 3 case reviews, and we're going to show you different techniques and different uses of the DAHL appliance. Now you have the understanding that it's an orthodontic appliance that causes intrusion in some instances and over-eruption in others. So let's look at the first case, which is one of localized wear. So we have a patient looking in front of us. The patient is 40 years of age. Okay, so what can we see? We see some diastemas, and we ask our patient, is the patient worried about the diastemas? The aesthetic result of that? No, perfectly happy. Okay, what else can we see? Well, let's just have a look at the upper left-hand side. I can see a very good long canine guidance, very short lateral incisor to the tip of the canine. Okay, and again, we've got a large amount of wear taking place on the distal incisal corner of that central incisor. So our patient is bruxing. We can see that from the amount of the wear facets that we've got in place. So we have a 40-year-old bruxist. What else can we see? Well, we can see some erosion occurring here on the labial aspects. And I can also see that the enamel is very, very thin on the mesial aspects of that too, incisal edge here, because I can see a lot of blue color coming through. So I'm not surprised that when we ask him to open, we see this effect. And in fact, the reason he's come to see us and has been referred to us is because he's got tooth sensitivity, hot and cold, and the diagnosis is that he is suffering from not only tooth wear, bruxing, but also erosion. So what we now need to do is to go and restore those palatal aspects. Our problem, of course, is one that the lower incisors have now over-erupted and are contacting into that deep concavity. So remember, a little thing about over-eruption, what happens throughout life is that our teeth are constantly over-erupting. As you well know, if somebody loses a lower molar tooth at a young age, the upper molar tooth over-erupts. Lower molar behind it tilts forwards. If that patient then, let's just say, split mouth study, lost a lower six at the age of 55 or 60, then we would not see the same amount of over-eruption or tilting of the tooth behind. Why? Again, it's this cellular turnover which has slowed down. So over-eruption is a phenomena that involves alveolar bone growth and cementum deposition. And this is occurring throughout life. We have an equilibrium that occurs between wear of teeth and over-eruption. So if we have a case now like this, where we've got erosion occurring on the palatal aspect, as we get 10 microns of erosion occurring, we get 10 microns of over-eruption of the lowers. So we now have a situation where our lower incisors are contacting in the middle of those palatal aspects. And of course, my problem here is one of space. I do not have space to put my restorations in. So again, you could decide, I'm just going to put some fillings in these teeth, make them so that they are 2 to 3 millimeters thick, and let it all bed in. And from time to time, probably 5 or 6 times out of 10, that will work. The other times it won't work. And the other times you'll get some tilting of the lower incisors or tilting of the upper incisors, because we've not gone through those 4 principles or those 4 techniques. So let's go through and do the classic approach. Okay, and you can see how thin, you can see better now on the mounted study cast, just how thin and how much erosion is occurring here. And we've lost 2 to 3 millimeters of tooth tissue. So I'm looking to put 2 to 3 millimeters in the deepest part of restorative material back. And that restorative material could be composite, it could be ceramic, it could be metal backings. Okay, we've got all the different types of restorative material that we can use. So let's look at alternatives first of all for creating space. Knowing that we've got the DAHL appliance at the bottom, and we can do that, and that's what we're going to talk about. But we need to look at alternatives, especially with our patients who are older patients. If this patient was 65 years of age, for instance, would I do the DAHL appliance? No, I wouldn't. I'd look for alternatives. Okay, and one of the alternatives is, let's just be very straightforward about it, trim the lower incisors. And sometimes that will be the best way, best technique, best treatment for the patient. Different case altogether, but this is a case where we're going to be doing a full upper arch reconstruction. We're taking the patient from a class 3 to a class 1 occlusion and increasing vertical dimension. Again, my problem is space, and therefore I've decided, because my lower incisors are over-erupted, we've got some rough incisal edges there, that I've just trimmed them down. And I've taken about 1 millimeter, 1.5 millimeters off them, just so that I've got a flatter occlusal plane. And a flat occlusal plane, lower incisors are all at the same level, okay, is very, very useful to the longevity of your restorations. It means that guidance, it means that disclusion can be easy, can be shallow. As soon as you start to have incisors at different levels, or posterior teeth at different levels. We're talking about occlusal planes now. As soon as you have occlusal planes where one tooth or two teeth are above the standard occlusal plane, that means that your guidance now has to be steeper to disclude that tooth. Steeper than it should be, steeper than the masticatory system would like it to be. And that then puts stress into the masticatory system. It puts stress into the jaw joints, temporomandibular joints. It puts stress into the muscles. It's put stress on the teeth and also the periodontal ligaments. So whenever you can, with restorative dentistry hat on, make sure you've got even flat occlusal planes. So for several reasons here, the patient's age, the fact that the lower teeth are over erupted, the lower teeth are uneven, I want to flatten the occlusal plane. So don't neglect what sometimes is an obvious choice. Another one would be to increase vertical dimension. So let's just look at this case and just see a little bit closer. So here's our full upper model. We've got the erosion occurring here, okay, and the lower incisors are contacting. So what would happen if I increase vertical dimension? If I increase vertical dimension all the way around the mouth, then I would gain space between the upper and lower incisors. Now, how can we gain vertical dimension? Various ways. In this case, it would be pretty straightforward, because if we look at his posterior teeth, he's got an amalgam in here. You can see an amalgam there, an occlusal amalgam, an MO amalgam, MOD amalgam, MOD amalgam, MOD, and fractured distobuccal cusp. So he's got restorations in all of his posterior teeth. So here's an idea for you. Rather than the DAHL appliance, a case like this, you can also go and replace all of his posterior restorations. Okay, we wouldn't do that normally if those posterior restorations were all pristine and good, but they're not. You can see that they are very hollowed out. We've got very steep cusp angles, which is a problem to us. Some of them has chipped. Some of them look as though they're leaking. So replace all the posterior dentition, posterior restorations. That can be done in composite, can be done in gold, ceramic, okay, amalgam. It doesn't really matter, again, which material that you're going to be using. But when we come to do the occlusal surface, rather than having the central fossa very steep and very deep, bring the central fossa up by 1 millimeter or 1.5 millimeters. So now our cusp angles, instead of being very, very steep, our cusp angles are shallower. So we're going to raise up the occlusal central area, okay, with our restoration. Of course, when we do that, that means that I've raised the bite on all of my posteriors, and my anteriors are now spaced. We've got some space there. So, question I'm always asked, and this is an important aspect, so please listen now. Question I'm always asked, do we do the anteriors first and then posteriors? Or do we do the posteriors first and then anteriors? Okay, so a question to yourself, have a think about this. Which way round do we do it? Do we go and do our definitive restorations on our anteriors? We're not talking DAHL appliance now, we're just talking raising the vertical dimension. So do I go and place my final definitive restorations here, then the space between my posteriors, I replace the restorations and make sure that the lower posteriors are hitting the upper occlusal surfaces, number one. Or number two, do I just go and replace all of the posteriors, gain some space then between the anteriors, and then fill up the space between the lower anterior teeth? Okay, it is nearly always, always, always do it the first way around. Let's see, what do we want from our restorations? What do I want from an anterior restoration? I want aesthetics. I want phonetics. I want guidance. What do I want from a posterior restoration? Aesthetics? Not really, okay, to a certain degree, nowhere near as much as an anterior one. Do I want phonetics? Phonetics doesn't really matter on the posterior teeth. Most of our talking, our words are formed between the anterior teeth. The S sound, the th sound, okay? That's all between anteriors. And what about from an occlusion point of view? What do I want for my posteriors? I want one positive, they need to meet. I need to have 3 points of contact, stability. Then I want a negative, the fact that they disglued, they do not meet when we go from side to side. So I need an awful lot more for my anteriors than my posteriors. So here's the clue. Do the anteriors first, get the correct aesthetics, make sure the patient can talk properly, and you've got the right guidance in protrusion and lateral excursion, and then fill in the spaces at the back. Do not ever do the posteriors first and then the anteriors. The only time I would consider posteriors first would be if the spaces between the posterior teeth, I'd fill in the posteriors with some temporary bridge work, not definitive, temporary bridge work. Then I'd go back and do my definitive anterior work and then definitive posterior work. So it's always done in that particular way. So that's another option in this case. Next option is, we mentioned 90% of our patients have a slide from RCP to ICP. And that slide, okay, because we're on a hinge, we hit and move forwards. That slide will also always have a horizontal and a vertical component to it. So if we take our patient back to that RCP position, okay, here's our RCP position at the moment. And as you can see, every single tooth is apart. Now, if we take the patient back and we do an occlusal adjustment, if the patient has a significant horizontal shift, 10% of patients have a significant horizontal shift. That means that if we look at their lower incisors, here's their lower incisors in intercuspal position. Here's their lower incisors now in RCP. Okay, there's a slide that's upwards and forwards. Okay, so once we've now gone and done an occlusal adjustment, we've eliminated the vertical part. The horizontal slide is still there. And that horizontal slide means that the anterior teeth are not meeting, the posteriors are. What we've done is, in effect, created space. So we've created space between the lower incisors and the upper incisors by allowing the mandible to move backwards and upwards to its normal, ideal RAP position. So if you have a significant horizontal slide, when I say significant, how much is it? Well, if your slide's only 0.5 millimeter, then you're going to gain 0.5 millimeter space. That won't be enough in a case like this. In a case like this, I need to have 3 millimeters, 2 millimeters, 4 millimeters maybe of horizontal shift. And you'll find that in approximately 10% of your patients. So people with a horizontal slide, a significant shift between 2 and 4 millimeters, 10% of the patients, one of our options is to go and do an occlusal adjustment, make RCP and ICP the same, allow the condyles to move upwards and backwards to RAP, get good interdigitation between the posterior teeth, and have space between the anteriors, which you can now restore. And our fourth, and the one that we're going to show you now in this particular case, is our DAHL appliance. So you've seen these before. This is our case where we've got our mounted study casts around RAP. We've increased the pin by a couple of millimeters. So I've now got a thickness in the middle here of about 3 millimeters. And I've done my DAHL appliance. My DAHL appliance is nickel chromium. So it's the same sort of appliance as it would be for splinted adhesive Maryland style wings. The first DAHL appliance, in fact, is original paper by Bjorn Dahl, 1975. This was before Maryland's came out. This was before any sort of adhesive bridge work came out. And so his DAHL appliance was in fact a removable chrome denture. A removable chrome denture with a palatal bite platform, which was used all the time. The chrome denture wasn't there to replace teeth because the patient had a full set of teeth. It was just a chrome denture with a palate. And the chrome went onto the palatal surfaces of the upper anterior teeth, and again at 90 degrees to the lower incisors, so it pushed those lower incisors down and gained space that way. So the original concept was in fact removable. So we've organized our DAHL appliance to our 4 principles here. We're now going to put it into the mouth, and make sure when you put it into your mouth that you do not use Panade or anything like that, because otherwise you're going to have a real problem getting this back out again. So we put it into the mouth with our standard glass Arnima cement. Now, in order to get this in and out when you want to, please make sure that you find a purchase point. Okay. Now, my purchase point is just here. So as we just go back one, as this is made so it fits up very flushly on the palatal incisal area, just before I fit this, okay, if this is my DAHL appliance tooth and here's my DAHL appliance, I now just bevel back the incisal edge of my DAHL appliance so that there is a gap here between the incisal edge of my DAHL appliance and the incisal edge of the tooth. And that gap means that when it's filled with cement, I'll have a thicker cement lute just in that one area, which then means when I come to get this off, very easy, thick cement lute or wide cement lute, take a fine fluted carbide burr, go into that space and cut some of the excess glass Arnima away. You now have a crevice in which you can get a flat plastic, get an instrument and rotate, and it comes out very, very easily. So make sure you give yourself the option, the ability to take this on and off when you want to. So this is where we're starting off, okay? This is now our DAHL appliance, okay, in place. And this is, initially it's in place, still got a little bit of cleanup to do, and you can see what's happened. Okay, have a look at the canines again. Here's my canines in contact. You can see specifically very well here. And now the canine are about 1.5, maybe 2 millimeters out of contact. So let's just go and see what the patient will feel, what the patient's going to feel about this. So number one, remember, the DAHL appliance done correctly is an anterior bite plane, an anterior occlusal splint. And therefore, what do we do? When do we use those? We use those when we have muscle problems, TMD problems, headaches. So our patient will not feel uncomfortable at a TMD or muscle level. If anything, he'll feel more comfortable. If somebody's got a degree of muscle tension, then that will go, that will resolve. So that's number one. The patient will feel more comfortable in his joints and his muscles. What about chewing? Patients used to chewing, obviously. You've now stuck a great big thick lump of metal behind the anterior teeth. Is he going to be able to chew his food properly? Answer is, of course, no. Okay, he's going to struggle to chew his food. Will it be painful? No. Will it be uncomfortable? No. Will it be different? Yes, it will. He'll just be chewing on those front teeth, won't be able to get his back teeth together. So chewing will be more lengthy, but it will not be, it will not interfere at all, it will not be painful. If our DAHL appliance is 3 millimeters thick at the front, how much space is there at the back? Remember the 3-to-1 rule. So if I've increased vertical dimension by 3 millimeters at the front, my posteriors are out of contact by roughly 1 millimeter. So what I'm asking for is for the 7s, let's just say we've got 7s here, the upper 7 to over erupt by 0.5 millimeter, the lower 7 to over erupt by 0.5 millimeter. So I'm not asking for a huge amount. I'm asking for a lot more here. I'm asking for maybe 1.5 millimeters or 2 millimeters of over eruption here, but I'm only asking for 1.5 at the back. So how long will that take to occur? We mentioned earlier that DAHL appliances work better when we have a younger audience or a younger patient. So if my patient is in the sort of 20 to 30 age group, then I'd expect my DAHL appliance to take 6 weeks to work. Okay, very, very rapid. We go to our 30 to 40, then I'm thinking probably more like 10 to 12 weeks. Okay, 3 months. I go to my 40 to 50, I'm thinking 4 to 6 months. I go from my 50 to 60, it could be 6 to 9 months. And remember, if my patient's waiting 6 to 9 months just to have the palatal aspects restored, then there are other quicker methods that you might want to go to. So remember, our DAHL appliance is there mostly as a treatment for our younger patients, okay? So we have alternatives. So how long will it take for those molars to over-erupt? Again, depends on age. Our patient's 40 years of age here, so I'm going to expect that it's going to be 3 months or so to get full contact. And therefore, how long will it be between these teeth over-erupting? I would have thought within a week or maybe 10 days, those teeth are in contact. What's happened now? Our patient now has a tripod. They're contacting at the front, they're contacting at the back as well, because remember, those are going to be the first teeth that come into contact. Then it'll be the 6s, then the 5s, then the 4s, and eventually the 3s will come into contact. So after about 7 to 10 days, our patient should feel more comfortable. They can get their back teeth together. They have a tripod, and that suddenly makes things life a little bit easier for them. So we're now going to wait until these teeth come into contact. What's our end result? Our end result is that all the posterior teeth and the teeth that were out of contact, so it's also canines, so it's all the canines, both canines and all posterior teeth are all holding shim stock. When they're holding shim stock, it's now time to take the DAHL appliance off because it's done its job. Okay, so again, our DAHL appliance has now fulfilled its criteria. Look again to see what's happened. Here's our starting point, canines in contact, DAHL appliance put in place, canines out of contact by 1.5 to 2 millimeters. 3 months later, canines back in contact. So our DAHL appliance has now done its job. All the back teeth are holding shim stock. It's time to take it off. On the other side, we can look and see, here's our premolars out of contact. About 1 month later, the premolars have now over erupted. So we've got probably just about 0.5 millimeter waiting to occur, waiting for the teeth to come into contact. As soon as all of those posterior teeth are in contact, holding shim stock, we take the DAHL appliance off. Important, don't discard it, okay? By all means, if you're going to do your final restorations as being a direct restoration, then now's the time to go and fill those spaces in. In my case, I was going to take an impression and we're going to make some palatal porcelain veneers, non-preparation palatal porcelain veneers. Going to last far longer than the composites will last, and the patient was comfortable spending that extra little bit of money for longevity. So this is where, again, that DAHL appliance will come in place. I take the DAHL appliance off, I do my impressions, I do my jaw registration, I take my face bow. My impression is silver plated, so I have silver plated dies, and then my technician makes those 4 palatal veneers. Obviously, that's going to take him a couple of weeks until the veneers come back. What do we do in the meantime? If we leave our patient, then those lower incisors will just do that again. So we have to put our DAHL appliance back in place, again as a temporary measure, until such time as we see him to do our final cementation. And here's our initial view, and there's the final view with the ceramic restorations now in place. And again, from the front, looks no different realistically, apart from the fact that you cannot see through these areas as much. And there's the case finished. Okay. Now, with an erosion case like this, guys, we always have to look at the erosion as well and make sure that the erosion, the reason for the erosion, okay, the diagnosis, okay, and the treatment of the erosion also goes on at the same time as my DAHL appliance. Why have we got erosion in this case? We've got erosion because of gastric reflux. So it's important that this patient goes to see the gastroenterologist as well, and we've got a leaking esophageal valve coming from stomach all the way up into throat. And this patient also will need to wear a mouth guard at nighttime with a little bit of antacid in the mouth guard. Okay, a little bit of milk of magnesia or something like that, so that if we do get some further acid reflux, it's not going to go and start destroying all the way around the porcelain veneers. So, nice case. We're going to move on to our second case now. Our second case is getting a little bit more expansive. So we've now got a patient who's got generalized wear occurring on his upper 5 to 5. This is a case now, not erosion. This is a case purely of bruxism. So here's our patient, and our patient, this is our patient smiling, and this is our patient with his E position. He's got some pretty unusual looking lips here, and those lips are very distorted because he's not used to smiling. You'll see his teeth in a few minutes time, and his teeth are worn very, very flat. You cannot, in fact, see his teeth when he does the M position. Okay, so we've got probably a loss of vertical dimension at the same time. And remember what DAHL appliances do? Because they open up and they allow over eruption, you increase vertical dimension on the patient. With a lot of patients, that will improve their facial aesthetics. So always be aware that the DAHL appliance can improve facial aesthetics in some patients, can make them look a little bit thinner in the face, and can also take away some of those nasolabial folds. So this is him going Emma, this is him smiling, and this is the E position. And we have very distorted lips. And it's important now that you take this on board. The distorted lips are going to be a huge problem for you if you're going to do some anterior aesthetic restorations. And the reason is that there is a unique to that patient relationship between where the incisal edge of his lower teeth and his upper teeth should be in relationship to his lips and also age. So if we're going to go and do some restorations for this gentleman, okay, and we are looking to do some restorations, we're going to do some restorations from 5 to 5 to make his teeth longer. And it doesn't matter whether those restorations are going to be veneers, composites, crowns, etc. Still the same principle. My principle here is I need space. And I'm going to get the space by using the DAHL appliance principles. So we're going to open up the vertical dimension. We're going to open up the vertical dimension with prototype restorations on the 5 to 5. That will mean that his 6s and 7s are now not in contact. And then once I've got the 6s and 7s in contact, take off the prototypes and put my definitive restorations in place. So we're going to use the DAHL appliance, but this time, rather than just being metal backings, they're going to use prototype restorations, temporary, that have been made deliberately high. So when I put them in the patient's mouth, the posterior teeth are apart. And we allow the posteriors to over-erupt. Once the posteriors have over-erupted, we can then go and take off the prototypes and put our individual crowns in place, knowing that I've got posterior stability at the back of the mouth. So we've done a little bit of tooth whitening first of all. Then we go into our diagnostics. Our diagnostics include, in this case, because it's a smile makeover, it includes showing the patient what his teeth, his smile is going to look like. So this is smile imaging, care of Tracy Ruck. And we also do our mounted study cast around RAP again. And our mounted study cast, on that, we've now done our diagnostic wax up, 5 to 5, made the teeth longer. We've also made the diagnostic wax up into our prototypes. Our prototypes are one piece from the 5 all the way around to the 5. You can see now from the front. And because we've opened up vertical dimension, just think what's happening here, guys. We've got edge to edge. When I open up vertical dimension, my mandible, again, because I'm on a hinge, okay, my mandible will drop backwards. Okay, so as well as coming downwards, it will go backwards. And look at this now. This now gives me the ability to lengthen my anteriors. At the moment in this position, I have no way of lengthening my anteriors. Only way I can lengthen them is to open the patient up and the lower incisors drop downwards, also lingually, and now I can lengthen them. And that's what we're going to do in this case. So we prepare the anterior teeth. Patient's going to have crowns on here, but part of the preparation is minimal or no preparation on the palatal aspects. We're putting a finish line in place, but we're minimizing the amount of reduction on the occlusal surfaces of the 4s and 5s, not taking any palatal enamel away on the anteriors. So it's a minimal preparation because we're going to be using the DAHL appliance to create some space. The only preparation I'm using is a finishing line. We now put our prototypes in place. Our prototypes will be high in the fact that they are contacting from 5 to 5, but the 6s and 7s, both sides, are not contacting. And we've now created, by opening up the space, we've created the anterior guidance required in this case. We're going to do a reorganized approach here. So we're going to have 5 principles of occlusion into this reorganized approach. And what we do now is we now wait. We now wait. Our patient, as you can see, is around about that 45 years of age. So we're going to wait approximately 3 to 4 months for the DAHL appliance to start working. During that time, we've also got some anterior guidance. We can start to finesse his aesthetics, his smile line. We can wait for his phonetics to come back if we've changed them at all. Remember, we've increased the thickness on the palatal aspect, and that will always cause a little bit more difficulty in the fuzz and the s sounds. So we've increased that, give that a little bit of time for the patient to get used to it. And of course, don't forget his lips. I want those lips to be now a lot more relaxed when he smiles. Okay, and look at these lips now. So this is coming to the end 3 months later, and those lips are so much more relaxed than they were before. This is a huge point. Now I can really start to work on where the incisal edge of my uppers and lowers should be in relationship to my lips at rest, that M position, M. And we know for a 45-year-old that he should be showing maybe about 1.5 millimeters of lower incisal edge and about 0.5 millimeter, 0.75 of upper incisal edge. If my lips are distorted, then I'm not sure I'm going to have exactly the right relationship there. So my DAHL appliance is giving me time, it's buying me time, it's minimizing my tooth preparation, it's increasing my vertical dimension, it's allowing time for phonetics to improve, okay, and also to get my lips so that they're nice and loose and relaxed so I can do my final restorations. So DAHL appliance is really, really important. And I'd say as a general rule, if you are doing any anterior aesthetic crown work, and it's crown work for the first time, where you're looking to minimize, I won't say do no preparation, but minimize the preparation you're going to do on occlusal surfaces or palatal aspects, that you use this DAHL appliance principles. So by that, I mean, you prepare the teeth for your prototype crowns. Prepare normally on the labial, mesial, distal, palatal, just a finish line. So you've not taken anything off the palatal aspect. You now put your prototypes in, which are high, okay? And you wait for the rest of the teeth to over-erupt. With smile design, if you do things predictably, you don't need to hurry them. And I've got no problem saying to my patient, we're going to wait with these prototypes on for 3 months, make sure we get your bite right, make sure we get the aesthetics right, your soft tissue improves. At the same time, what I'm doing is allowing over-eruption to occur so I can do much more minimal preparation on the palatal aspects. Okay, think about that whenever you are doing any anterior aesthetic crown work. Okay, always go through your mind. Let's use the DAHL appliance principles to minimize tooth preparation. So here we are with his initial smile, his cosmetic imaging, his natural smile with his prototypes in place. We now, once the posteriors have over-erupted, are holding shim stock. It's now time to take the anterior prototypes off, do our face bow, do our definitive preparations and impressions, jaw registration, and get my final restorations made. And again, final restorations, as we said previously, with a nice ramp there to make sure the lower incisors are hitting at 90 degrees. And then these are bonded into position. These are some Emax restorations. But always remember, somebody who's a horizontal grinder like this, and if you're going to be placing Emax there, then the patient needs a slit. Okay, so you have your choices. When it comes to aesthetics, you have your choices between Emax, zirconia in the middle, and then PFM. Okay, and we know that PFM lasts longer than zirconia, zirconia lasts longer than Emax, Emax more aesthetic than zirconia, zirconia more aesthetic than PFM. So we have a decision to make based on longevity, based on aesthetics. In terms of tooth preparation, there's not a huge amount of difference going to be between the tooth preparation. Yes, PFM a little bit more in all probability on the labial aspect, but not a huge difference. So we're talking about longevity and aesthetics. If you want maximum aesthetics, then of course it's Emax, but that's the material that is going to be more likely to fracture under occlusal loading. So if you are going to put Emax in place, make sure if your patients are bruxist in the first place, remember the problem with bruxing, going to be bruxing for several hours a night, and forces are maybe 5 to 10 times higher than maximum biting force, then there's a chance that your Emax are going to fracture. Least chance of fracture, and for those patients who say, I do not want to wear a splint, I will not wear a splint, then you need to go back to PFM. Okay, you've got a really good chance that the PFM will not break, will not chip. And that gets a little bit less with zirconia, less with Emax. And again, our final aesthetic case, our final patient. So moving on to our final case now. And our final case is one of adhesive bridge work. So we're showing you the three genres, if you like, the three techniques when we'd normally do it. The classic DAHL appliance. The DAHL appliance you can use day to day when you're doing crown preparations. And the third one is our adhesive bridge work. You'll hear a lot of people, when we talk about adhesive bridge work, a lot of people will say, just put the adhesive bridge on high and let it bed in. And again, we have all the same problems that we talked about earlier. If we put it on high, and especially now I'm thinking about adhesive bridge work being single cantilever. Remember those of you that are doing adhesive bridge work, adhesive bridges work better in the maxilla than they do in the mandible. They work better as a single cantilever than as a fixed, okay? And adhesive bridge work can be, if you don't understand the principles, unpredictable in their success rates. And most of the time now, adhesive bridge work will involve a little bit of tooth preparation, intra-enamel tooth preparation, so that you can gain better resistance form. It's not the retention. We get our retention from the adhesive composite to enamel luting, and we get our resistance form from guide planes, rest seats, and grooves, all very tiny. So adhesive bridge work works best as a single cantilever. Now, one of our problems with adhesive bridge work is, again, space. You need anywhere between 0.3 to 0.7 of a millimeter of thick material. We'll call it non-precious material, nickel, chromium, etc. You need that wing to be a minimum 0.3 up to 0.7. I prefer 0.7. And some of the studies have shown that even at 0.5 and 0.6, that framework can bend under occlusal loading. Remember, your patient may be bruxing on this. So I prefer my metal wings to be 0.7 of a millimeter thick. Now, if I'm going to be replacing a lateral incisor off a canine, and I'm going to do it with a classic Maryland, okay, or a central off a central with a classic Maryland, I need that wing to be 0.7 of a millimeter thick. How do I get it? Okay, we've got the same ways. Number one, trim down the lower incisor, easy. Number two, trim something off the upper palatal aspect. Tooth's getting a little bit thin, enamel may be getting a little bit thin. In some patients, you may be getting through the enamel, but it's an option. Option number three, a little bit off the top, a little bit off the bottom. Option number four, think about increasing vertical dimension. We've talked about that previously. Option number five, think about RCP, ICP slide elimination. Option number six, put the bridge on high and let it bed in. But we've got the rules and regulations. If it's a single cantilever, we put it on high, what could happen? Rather than the lower tooth intruding, the upper may be forced labially. So if we are going to use as our definitive restoration, okay, a single cantilever, and we're not going to do any preparation at all, we are going to put it on high, we need to either, number one, put it on temporarily, but have another wing on, so it's a fixed temporarily, or number two, make a prototype, get the space, as in the DAHL appliance, and then put the definitive on. But remember, the DAHL appliance principle to put the adhesive bridge in high will mean you have to change, for predictability's sake, from a cantilever to a fixed in the short term. So let's look at our final case before we come up to the end of our webinar today. We have a simple case of what you'd think about a missing lateral. However, there's the lateral, there's the canine. So it's a supernumerary that's been lost, and the patient's just been wearing a little denture and coming to us, and we're now going to put a Maryland bridge in place. Okay, and what I'm going to do here is initially I'm going to use the DAHL Appliance effect, and I've put in a temporary Maryland, splinting the central, the lateral and the canine together. Why am I doing that? Well, I'm very worried that if I just put in a Maryland from the lateral, which is where I'm looking to do it, a Maryland from the lateral forwards to the supernumerary there. Why am I doing that? Number one, I'm doing that because I don't want to gray the upper central incisor. If I gray that upper central incisor, then I'm going to have a problem aesthetically between the centrals. Yes, you could say you can cut that in wing back. Yes, I will. You can also say you could do this in zirconia. Yes, I could. But in this instance, it's a little bit of an older case. I'm now going to be doing this in my traditional nickel chromium, chrome cobalt. So I put my splinted retainers in place. And if I didn't, if I just used that one wing there and said, I'll let it bed in, there's a chance that the lower incisor would not intrude, but would just push that upper incisor outwards. A little bit different with a canine, but here I'm using that wing. So that wing goes in place and it's altered. It's a fixed bridge. So I'm using this as a temporary. It's just got acrylic on the labial aspect. And once I've got my space, once the lower incisor has intruded, then I go and replace it with a 0.7 thick metal wing, cut back well short. I put a little bit of resistance retention form in, as I do with all my Marylands, and I've gained space. And there's my definitive Maryland in place. So thank you very much for listening. I'm very happy to take questions. I can see that we've got 3 questions already. In summing up, DAHL appliances are there better for anterior teeth, not as good for posteriors. Take home message, do it for anteriors, not posteriors. Do it for younger patients, not older patients. Think about the alternatives. Sometimes the alternative, much more logical, quicker to do. Those alternatives, trimming the lower incisors, doing an occlusal adjustment, increasing vertical dimension at the back if the patient needs restorations. If we are going to do a DAHL appliance, then make sure you use those 4 techniques, those 4 basic principles. Number 1, mount the models around RAP. Number 2, increase the vertical dimension so you have the correct amount of space to be able to restore at the end of treatment. Number 3, make sure that the occlusal plane part on the palatal aspect of the DAHL appliance is hitting the incisors at 90 degrees so it forces them down their long axis. It doesn't lingualize them. Number 5, make sure they're splinted together. Once that's happened, we wait for the over-eruption to occur. Once the over-eruption's occurred, we can take the DAHL appliance off. We have space. We can use 3 types of DAHL appliance. I'm sure there's more, but I use consistently 3 types of DAHL appliance. And I've been using these since I went to the Eastman. Bjorn Dahl, 1975, his original work came out. I went to the Eastman and did my master's degree between 87 and 89, 2 years, and we were taught DAHL appliances then. So I've been using DAHL appliances for 30 years. And I know what works and what doesn't work. And if you stick to the rules, you get that one word that we're all after, and that is predictability all the time. And we can use them as a traditional DAHL, we can use them with prototypes, and we can also use them with Marylands. But be aware that we do have to make sure that we don't have some of the problems of lingualization, of not mounting around RAP, and of course of drifting forwards. So thank you very much indeed for listening. I will now go on to the Q&A. Okay, so anonymous attendee, is chrome dentures same as metal backings but different name? Yes, it is. As I mentioned, the original DAHL appliance was a chrome denture with a backing on the palatal aspect. So by all means, you can go and do a palatal chrome. Okay, so if you've got teeth missing at the side, you can go and do a palatal chrome and just bring it onto the palatal aspects of the uppers. And by doing that, you'll create the same appliance. But again, remember that that chrome palatal aspect that's coming onto the palatal aspects of your teeth needs to have the horizontal plane in such a way that it now hits the long axis and hits the long axis of the lower teeth at 90 degrees. So we get intrusion. Canwal, I didn't get what is chips. I can only think, Canmore, you're talking about when I said Emax can chip. It can break on the incisal edge. Zin, okay, for case number 2, does the lab make the prototype crowns after the teeth have been prepared? No, no, no. Yin, lab always makes prototypes before your preparations. This is a gimme, happens all the time in fixed prosthodontics. Please go back and read your textbooks. We have number 1 mounted study cast, number 2 diagnostic wax up, number 3 the diagnostic wax up is then transferred and we make prototypes exactly the same shape. These prototypes are now thin prototypes. They're called shell prototypes. And we then reline these in the mouth and trim them in the mouth. Okay, so these are made so that they initially do not fit your preps, because guess what? The technician doesn't know what your preps are going to be like. So they're made artificially very, very thin, so that when you prepare the teeth, you fill the prototypes with Luxatemp, put them back into position, wait for the Luxatemp to harden, and then trim the margins. That way you get very aesthetic restorations. They fit beautifully around the margins. And the third and probably most important part is that they're lab and heat cured, and therefore they'll be stronger and they'll last longer. Sarah, thank you very much for a great lecture. Okay, Sarah, I'm glad you enjoyed it. Thank you very much for saying that. Imran, hello, Prof. In your last case, why did you not do a wing on the central instead? I tried to answer that. And the reason that I didn't do a wing on the central, 2 or 3 reasons. So from a treatment planning point of view, number 1, it may interfere with the aesthetics of the incisal edge. So very much aesthetics as we get further back in the mouth doesn't matter anywhere near as much, obviously. And the most important aesthetics are between your upper 2 central incisors. So if I'm going to get any graying at all that we can do with Marylands, even though we keep it away from the incisal edge, if I'm going to get any graying, I don't want it to occur on my 2 centrals. Okay, so remember, my abutment tooth is then in the canine region. I'd rather have a graying of the canine with the other canine than on the 2 centrals. So that's number 1 reason. Number 2 reason is I've got canine for canine guidance. I've got my central for protrusive guidance. I'm not using my lateral too much from an occlusion point of view. So I'd rather have my central in decent protrusive guidance and my canine in good lateral guidance. So those are the reasons realistically that I chose not to do it on the central. Next question, Catgo. If you have a case of localized anterior wear, 3 to 3, no space to build up in centric relation, and DAHL is not ideal, how would you restore the case with no DAHL? Okay, so we're still going to get space. So you can either decide to open up the whole vertical dimension. So do posterior onlays, or as I've mentioned in this particular presentation, replace any existing restorations, but making sure the central fossa is a little bit higher. So you're increasing vertical dimension. That's one way. Number 2 way, bite the bullets, go and do the trimming of the lower central incisors. Number 3 way, in 10% of the cases, you may have the horizontal slide. So in 1 or 10 cases, you can do an occlusal adjustment, mandible drops back, and the central incisors and canines all drop back to there. and now you have the space. So you've got three alternatives, okay? And those are the alternatives that we went through. Sarah, again, okay. What would be the best management for a case of moderate tooth wear in upper and lower incisors in relation to bruxism patients, bruxism plus diastemas between all incisors, and patient would like diastemas to be closed? Right, Sarah, I presume you've got a case that you're actually doing at the moment. So what's the best management for a case of moderate tooth wear? Okay, so the first question I'd have to ask you, and whether you're going to answer it now, I don't know, is does the patient want the upper anteriors restoring, lower anteriors restoring? Okay, from what we're saying is that the patient would like the diastemas to be closed, so we're going to go and restore the upper anteriors. Are we going to restore the lowers? So this will depend upon how much space you need, but you need space. If you're going to restore the lower incisors, you need space to be able to put some composite back onto. So again, DAHL appliance would work very well. And DAHL appliance can be just composite. We mentioned that previously. And if you're going to do a DAHL appliance which is just composite, please do not try and do it by hand. Get mounted study casts around RAP. Have a diagnostic wax up done so you can make sure that all the shapes are correct. Palatal platform hitting lower incisors at 90 degrees. Then take a putty matrix. Ask your technician for a putty matrix. Then in the mouth, we'll go and etch the palatal surfaces, incisal edges, whatever. Fill a putty matrix with composite and cure it. By all means, that putty matrix can be a silicone matrix. It can be a clear silicone matrix, so you can actually go and then light cure through it. And obviously there'll be a little bit of refinement, but you've got basically the right shapes. And then at the end of treatment, go through and de-splint them. So there's many ways. All depends on how bad it is and what the patient requires. So Sarah, if you needed any more help with that, by all means, email me some photos and I can advise you further. Dina, thank you very much for the session. Very informative. Can you provide us with a webinar on resin bonded bridges? Funny enough, Dina, yes, this one is coming up. Tomorrow I'm doing a webinar which will discuss treatment options for the missing anterior tooth. So I'm going to look at partial dentures, adhesive bridge work, conventional bridge work, and implants. So we're going to be discussing adhesive bridge work tomorrow. In about a week's time, I've then got another webinar purely on adhesive bridge design and adhesive bridge work. So stay tuned for those and you'll see them. Next one, how do you record RCP? This is Carolyn. Carolyn, I record it by bimanual manipulation. Lots of ways of trying to do that. Anterior jig works very well. Leaf gauge works very well. At the end of the day, you have to learn the bimanual manipulation technique. If you don't know it, then unfortunately, not easy to read and understand occlusion from a textbook. Most of the time you have to go on courses and be taught face-to-face practical wise. We do those courses at Tips and Training. We'd be delighted to have you as one of our students, but that's the real way that we really start to understand. And there's a lot of theory that goes behind that occlusion and that practical aspect first of all. Azim, if a patient needs a Maryland bridge, but there was inadequate space for the bite, how will you raise the bite? Patient has missing central incisors. So you can raise the bite only either with a DAHL appliance. So you put the fixed fix. I'm presuming now that missing two central incisors, you're looking to do a DAHL appliance for a Maryland bridge with palatal wings on both lateral incisors. So put it on, but make sure those wings are high. Make sure those wings have got the horizontal ramp, because they're splinted together, okay, much easier than if we're doing a single cantilever. With a single cantilever, we have to do a prototype first, or do a fix and then cut the wing off afterwards. With a fix bridge, you're already splinting together. So you put the bridge on high. It acts just like a classic DAHL appliance in case number one, and you wait for over eruption to occur. Next question. Alip, thank you for a great webinar. Very excited to put this into practice. What sort of retention would you usually use once you've completed the case? The idea behind all this, Alip, is that we don't need retention. That's the whole point. One thing we do need to do, which we need to be aware of, if we're creating a lot of space at the back of the mouth, then when teeth over-erupt, very often they don't just over-erupt vertically, they tilt. So if we have a lower tooth, so if I can just show you this now, okay, so here's a lower tooth. I know it doesn't look like one, but if that's the lingual cusp, that's the buccal cusp. Okay, if it doesn't contact the opposing tooth, it doesn't do this. So in the DAHL appliance, my lower tooth would not do that. My lower tooth will do that. So it will over-erupt, but it will also tilt lingually. As that happens, my lingual cusp goes down, my buccal cusp goes up, and my cusp angles steepen. Same thing, but opposite occurs in the opposing jaw. Okay, so here's palatal cusp, here's buccal cusp. If there's no antagonist, it will over-erupt not this way, it will over-erupt that way now. Where the palatal cusp comes down, buccal cusp goes up. So we have an increase in cuspal angles at the back of the mouth. So whenever we're using a DAHL appliance, we have to go back to the back of the mouth and make sure that we have not created any balancing side contacts or non-working side interferences. But stability, do it well, it's stable. You don't need any long-term retention. Imran. Hi, Prof. How long do you leave the DAHL appliance on average? Again, Imran, it all depends on age of patient, number one. Remember, young patient occurs quickly, old patients occur slowly, and the amount of space. So if I'm going to be using it for longer than 6 months, I'm really saying to myself, should I not be doing something different? I should be talking to my patient and saying, come on, we've got alternatives here. If you really want this doing to minimize any tooth preparation, then fine. But remember, 6 to 9 months is a long time to wait. So I'm going to be doing it in younger patients. And I suppose my average patient I see for this is 40 years of age. So the average time it's taking is about 3 months. Cat go again. Can you explain how to shape the palatal platform of direct composite restorations for DAHLs? How do you splint these if you want them to stay? Okay, yeah, good question. Cat go. So we go through the stages. Number one, please do not do these freehand in the mouth. You will struggle. Okay, and the whole point there is you don't do freehand crowns. Okay, you ask the help of your technician. So if we're going to do this and you want it predictable, which I think you do want it predictable, we all want predictability. Number one, mounted study casts. Mounted study casts around RAP. Number two, increase the vertical dimension so you've got the correct amount of space. Number three, building that platform. That's not you, that's your dental technician. Building in the platform so that the lower incisors, when they move up and contact, they're contacting at 90 degrees. Okay. Number four, now instead of making it, number four, do an index. So you've got these, let's just say 2, 1, 1, 2 again. You've got the palatal platform, the right angulation. They are splinted together, okay, with the diagnostic wax up. You then go and take a palatal index. That could be a putty index. It could be a clear silicone matrix. Take that out. Technician sends that to you. You then fill that, acid etch the palatal aspects, fill that with composite, stick it in place, and guess what? You've got the ideal shape. Now, when it comes to desplinting, you need to go and take a fine diamond burr, fine tungsten carbide, and on the palatal aspect, start to go in between the teeth, in the embrasures and contact areas. Eventually, you'll be able to get a very, very thin hacksaw blade down in between them, and you can repolish them. So it's not too difficult. It takes some time, so you don't lose the shape, but it's not too difficult. Amir, thanks, Paul. What is the name of the notch on the DAHL appliance that allows you to remove? It's not really got a name, Amir. It's just that we bevel it backwards. So it's just me. Before I come to fit it, I just take a burr and bevel that incisal edge. So instead of sitting there really, really beautifully and flush, it's just beveled back. Okay, so I've just got a thicker cement lute. So there's no real name for it, something you do. Asim, can we use DAHL appliances on posteriors? They don't work very well at all on posteriors. They can create occlusal problems. They can get the condyles to move. So you can try them. We don't have predictability. That's why you'll find that nearly every case you see, we do it with anteriors. Yes, there are case studies where we've done it with posteriors. Sometimes it works, sometimes it doesn't. But we don't have predictability. We have predictability with anteriors, as long as we stick to the routine that I've shown you today. Vipan, hi, how are you doing? Can you explain a little bit about freehand composite build-up for the DAHL principle? Difficult. So Vipan, you need to make sure that you probably overbuild the composite first, and then as you are adjusting, remember we have to do this to RAP, as you are adjusting, tapping the patient up and down, you need to make sure that you get 4 contacts. I assume we're just going to, again, mirror what I did with that case study 1. Get 4 contacts and start to adjust the palatal ramp so it's hitting at 90 degrees. Complex work, difficult work to do. Far easier to get a technician to go and do it and wax it all up. You have a putty matrix and you do that. It's the same thing we do nowadays with labial veneers. You can do it all yourself freehand. It takes a long time, or you can get a diagnostic wax up done. You can get a clear matrix. You can do the injection molding technique. That's far easier to get exactly the right aesthetics. So I suggest you use that. Okay, Jude. Thank you, Professor. So insightful. Okay, I hope you enjoyed it, Jude. Anonymous, can you explain, please, the horizontal adjustment that you need to do when there's a significant horizontal slide? Okay. We have 90% of our patients have a slide from RCP to ICP. That means that 90% of our patients are walking around with the condyles down here rather than the condyles in their ideal position. We want to, wherever possible, and only if we see signs and symptoms, we don't do this for no reason, but if we do see signs and symptoms of wear, TMD, remember 90% of your patients probably have those signs and symptoms, we would like to create a masticatory system where the joints, the muscles, the teeth, the ligaments are all in harmony. Starting part for that is to get the joints into RAP. Automatically, if the joints are in RAP and they are reasonably healthy, the muscles will be at their most relaxed. We then build in an intercuspal position. So 90% of our patients have a slide. 90% of slides have a larger vertical and small horizontal component. Only 10% of slides have a large horizontal component. So what we do now is, if we can first of all diagnose, and this is for you, can you diagnose what's a horizontal slide and what's a vertical slide? If you can't do, then forget this conversation, okay? You can't do it. So the first thing you have to do is make sure you're on good occlusion courses where you can identify what's a horizontal, what's a vertical. If you now identified it's a horizontal slide, we do an occlusal adjustment, occlusal equilibration, and we tap the patient up and down and adjust the first point of contact, maybe here or here or here or here or here. And we keep on doing that until all the posterior teeth now contact together at the same time. The mandible will drop back, and therefore we have space between our anterior teeth. That's all I can say. That is a huge topic. Okay, textbooks are written on this. We have several days on occlusion courses on this, but that in essence is 1 minute answer. Negin, hi Paul. In which only case it was that we should build up posterior teeth before the anteriors? The only time I would do it, and this would be on a temporary situation, so I'd never do it permanent. I'd only do it temporarily, whereby, excuse me, we're missing some teeth at the back. We don't have posterior stability. Therefore, we always, before we do our anterior restorations, need posterior stability. Okay, remember the routine we do. Create posterior stability. Prepare anterior teeth, get anterior guidance. Restore anterior teeth, restore posterior teeth. That's the way that we do things from a treatment planning point of view. So if I didn't have posterior stability, I would go and do something at the back of the mouth first of all to give me posterior stability. And I would do that in a prototype or temporary measure. I now have temporary posterior stability. That will give me the option to now go and work on my anteriors. So I will always do anteriors before posteriors definitive, but sometimes I might do posterior temporaries before anterior temporaries. Hope that answers your question, Nick. Vipin, again, can you please explain a little bit more about freehand composite build-up? I think I've answered that. Yes, I have. Anonymous, how do you bond composite to amalgam if you don't want to remove old amalgam? Number one, I don't think that I would normally want to do that in any case. I would want to take the old amalgams out. Who knows what's happening underneath? Well, the old adages of restorative dentistry is if you're going to do a definitive restoration on a tooth, then make sure that you own the core. So always go and take out somebody's old restoration. Never keep restorations in place if they're not done by you. So I don't think I would ever do that. If, for whatever reason, it was one of my old restorations and I wanted to do this, and I can't think why, but if I did, I would sandblast the amalgam. I would then use Panavia to get a bond between the composite and the amalgam. A little bit like you would do between metal, but sandblast the amalgam first. Ready, thank you, Prof. If I'm using Maryland bridge made of zirconia, which type of cement do you use? There's a whole, I can't go through that now. There's a whole protocol ready. We'll do that when we come to look at Maryland bridges in a week's time. Carolyn, what is a good cement to veneers and DAHL appliance and wing bridges? I use Panavia for my metal. If I'm doing ceramic, then I'll use a dentine bond and a flowable style of composite, usually something like Choice or Nexus. Which lab do you use for DAHL cases? I use a lab in Sheffield, Gary Jenkinson. He is Art Laboratory in Sheffield, Gary Jenkinson. Anam, is diagnostic wax-up required for single crown or 3-unit bridge? Anam, how predictable do you want your restoration to be? You cannot tell. I cannot tell what my restoration is going to be like unless I do, number one, cosmetic imaging, number two, a diagnostic wax-up. Now, with one tooth, yes, you've got your imagination, but does the patient really know what it's going to look like? The more that you do, or one tooth becomes 4 anteriors, becomes a full mouth reconstruction, you need to have your wax-up. So as a rule of thumb, always do a wax-up. Okay, I always do a wax-up. I always. Medical legally, nobody can come and say that was a waste of time, because I now know functionally the end result. And I do cosmetic imaging for every case, so the patient knows functionally and also cosmetically what the end result is going to look like. Okay, so the answer is always. Brindusa, thank you very much. Thank you, Brindusa. Can't go again. Do you always need to restore the posteriors when you want to restore the anteriors in centric relation? Okay, so we take somebody back to centric relation, okay? Usually, okay, there will be 90% of the time an RCP contact. If we're going to be working around centric relation, usually we then do an occlusal adjustment, so RCP and ICP are the same. So in cases like that, sometimes we don't need to do anterior restorations. Sometimes we don't need to do posteriors. Sometimes we need to do anteriors and posteriors. So it doesn't realistically depend on us working in centric relation. It depends on so many more factors. Are we increasing vertical dimension? Are we going to do an occlusal adjustment? So it's an answer, it's a question that's got too many different answers and not enough information to guide us. I'm sorry, Katko. Great and simply informative. Thank you very much. From the Philippines. Okay, very nice. Mabuhay from the Philippines. Very nice to see you, and I'm glad you're listening. Azim, very important. Does your course prepare for MPROS? It doesn't specifically. Yes, of course it does. It gives you all the information you need, but it is not a specific MPROS course. Our course is accredited by the Royal College of Surgeons. It is not a specific course for the Royal College of Surgeons for MPROS. It is just a accredited restorative and aesthetic course by the Royal College of Surgeons. I think we're the only one in the UK, and there may be one or two others worldwide that have the same. Azim, if you have crowned the posteriors before the anteriors, what will happen? Good question, Azim. The reason we say never do it is if you crown the posteriors, you have set cusp angles. Okay, so you've got a certain occlusal shape, and that occlusal shape will mean that your cusps have a certain angle, shallow or steep. Okay, now let's look at the worst case scenario. Your technician has made beautiful looking posterior restorations with steep cusps. They look beautiful. Now you have to have steep guidance to overcome steep posterior cusps. Remember, occlusion wise, your guidance at the front has to be steeper than cusp angles at the back. So simply you say, okay, I'm going to have steep guidance at the front. Our masticatory system does not like steep guidance. Steep guidance puts stress into the masticatory system. Therefore, some patients, if you give them steep guidance, they complain. They get temporomandibular joint problems, they get muscle problems. Sometimes the teeth can become mobile. So what you're doing is you're setting posterior inclination and you're making the patient have to have steep guidance. That's wrong. What we do is anteriors first, get the guidance so that the guidance is shallow and comfortable, and then have our posteriors, which are slightly flatter than our anterior guidance. But very good question. Sarah, what would you use to cement composite DAHL appliances, to cement composite DAHL appliances? Just a composite lutein cement. Again, acid etch, dentine bond, and Nexus or something like that. Vipin, thanks a lot. Okay, Vipin, no problems. DR, how you treat lower incisors worn from old patient? Exactly the same way, DR. Create space. Okay, hammer those lower incisors with the DAHL appliance. Put the DAHL appliance onto the upper. Nothing wrong with the upper, but put the DAHL appliance on the upper. Don't put the DAHL appliance on the lower. Don't do that. Put the DAHL appliance on the upper. Okay, we'll throw the DAHL appliance away at some stage. On the upper, that intrudes the lower incisors, allows the over eruption. Take the DAHL appliance off. You've now got space between lower incisors and palatal aspects. Then just increase the length of the lower incisors with composite, with crowns, with veneers. Negin, thank you. Thanks, Negin. Can't go. Which cases are an absolute contraindication to use the DAHL? Good point. What cases? First of all, the older patients. Okay, don't even bother with the older patients. It will take too long. Anybody else? Somebody who's got chronic TMD. Okay, chronic TMD, you wouldn't use an anterior bite plane. You'd use a stabilization slit. So somebody's got chronic TMD, an older patient, and anything at the back of the mouth. Those would be my contraindications. Amir, just going back to building posteriorly before anteriors in cases lacking posterior support. Will you consider denture as an alternative to a prostate bridge? No. Unfortunately, Amir, dentures, especially dentures which are mucosal borne, sink in. I was doing a webinar in the not too distant future on stable base dentures. They're the only occlusally stable mucosal borne dentures that you can do. They're out there in the literature. So if you want to go and learn about stable base dentures, have a look at it. Michigan University, Joe Clayton concept. And that's been out there for many, many years. We've done a lot of stable base dentures. And that's the only posterior one, denture, which is mucosal borne, which is stable. Otherwise, I wouldn't consider a mucosal borne normal acrylic or chrome denture to have a posterior stable dentition. Hello, Michael. Yes, how are we doing? Great lecture on DAHL. Have you had a chance to use Pretal zirconia? I've done one, two, three. I've done three. I've had one failure. So not great at the moment, but we are learning. I think the important thing about all these, Michael, is they've got to be thicker. You've got to make sure the guidance is correct on them and thicker, because we just know that the connector between zirconia and Pontic isn't going to be anywhere near as strong as between metal and Pontic. So we've got reasonable studies on them now. We've got some 10-year studies on them, and I am doing one or two more. I was reticent. I'm now starting to bring those in. So I've done three, one fractured, and so 2 out of 3. Not what I want for predictability, but we will wait and see. And in all of those cases, it is very much the patient aware that they are pushing me to do it. So it's not me suggesting it. And if there was a failure, then we went back to alternatives at their cost. They knew that. Carolyn, which one is good imaging software? So the one I use is Smile Imaging by Tracy Rook. She did a webinar for us not too long ago. If you want to email me, I'll give you her, I don't know off the top of my head, her details. If you want to email me, Carolyn, drpaultipton@gmail.com. Azim, if RCP equals ICP and we need space, what can be done then? DAHL Appliance, Azim. So we have to, you know, the RCP ICP slide is only for some patients. We have to have alternatives. So if RCP and ICP are exactly the same, we now need space, trim down the lowers, build up the posteriors, or DAHL Appliance. Anam, what are the steps of restoration in doing diagnostic wax up? First of all, Anam, you would get your technician who understands a diagnostic wax up. So it is a matter of taking impressions, Facebook registration, jaw registration around RAP. So you mount the models around RAP, take the wax record out, close them on. We then do our diagnostic wax up. I just say to my technician, do me a wax up, and then I give him a list of everything that I need that wax up to look like or to function by. Okay, and then he includes all of that information in the wax up, sends it back to me. Sometimes once it sent it back, I review it and say, no, that's not really what I was looking for. Go back and change 1 or 2 things. So between us, we'll get the end result on our mounted study cast. I know the end result, technician knows the end result, patient knows the end result. We can then start to move forwards. Anonymous, thank you from Kenya. Okay, Anonymous. We should go on the restorative course with you. Did the implant one a few years ago. Restorative course, even though I say it myself, it's occlusion based, and I don't think there's any better course out there in terms of teaching you good quality, occlusion based, predictable restorative dentistry. Okay, moving on. Last 2 questions. What is your opinion on bilaminate splints, hard and soft, for wear cases? Don't like hard and soft. Why? If it's soft on the inside, it can move. And if it moves, therefore, it will not give the guidance that I want it to give. Okay, I want a hard acrylic splint that is rigid in the mouth, so that when I go into right lateral movement, it doesn't move and allow posterior teeth to come into position. So absolute no for me. Azim, will crossbite or scissor bite affect DAHL process? Could well do. Yes, could well do. We have to mount our study cast, number 1, and then work it out. Most of our teaching and all the teaching we do initially is always based on a class 1 occlusion. Once you understand class 1s, you can move to class 2s, class 3s. But you have to understand the basic principles of class 1s first of all. Okay, guys, I hope you enjoyed all that. 45 questions, 80 attendees. We have another one coming up tomorrow. Please have a look at that one if you can do. I'm going to talk about missing anterior tooth and different options. So from me, from Tipton Training, from Bar.